Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
Hell yeah, Wawa.
Yeah.
Yeah,
We got it down here too.
How long has Wawa been in Florida?
It started in Florida, I want to say probably like 2012-ish when we started seeing pop up.
Wow.
Yeah, it's been a
Excellent.
godsend. It's been a godsend.
Yeah. Well, this is your first time on the podcast, so why don't you give people a quick 15-second intro?
Yeah. So my name is Paul Sheats. I've been involved in EMS, been a paramedic for about 18 years now. The past 13 of those years, I've been working as a flight paramedic for a hospital-based program. We do a mixture of, we do rotor wing. We do a mixture of scene work and interfacility work as well. And then for the past 8 years, I've been adjunct instructor at a local paramedic program that's associated with a college. It's a 12-month paramedic program. And over there, I primarily deal with the lab setting, the skills, hands-on skills and scenario portion of everything.
And I believe that's what we're here to talk about today.
Yeah, we're going to talk about some sims. We're going to talk about scenario-based training, skill-based training, and really kind of how we can improve on that as instructors and just basically how important it is.
Well, I'll let you have the floor. Take it away.
All right. So the beautiful part about, simulation-based training and skill-based training is it really is the only setting that we have to improve our craft without significantly harming the general public. And I think that's a very important thing to recognize and to utilize, because we do call it a practice of medicine and everything, and to a certain amount of extent, we're going to make mistakes on our patients, and that's understandable. But the goal is to truly avoid the mistakes on our patients by making sure they happen in plastic, and on rubber, and settings that we can debrief those scenarios and learn from those scenarios. I kind of view instructor the same way I kind of take my clinical background. I know you're kind of the same way, Mike, is that constantly trying to get better. And the way I did things as a paramedic 5 years ago is very different than the way I do things now. It's probably going to be different than the way I do them 5 things from now. And I think, as instructors in EMS education, we should really kind of be pushing for the same thing. I don't teach the same way, teach the same things that I did 5 years ago. And hopefully 5 years from now, I'm not going to do that either. So, a lot of the stuff that we're going to be talking about is based on the education and training of paramedic students, of EMT students. But I think a lot of the topics, there's bleed over that for these concepts that can be used by in-house education departments for EMS education. The difference between an in-house EMS education program versus a true paramedic school, paramedic program is, one's got a grade, one doesn't have a grade. And the remediation process looks a lot different. But the overall training, there's some pretty significant similarities. So, my experience is more in the student lab setting, but I think there's a lot of bleed over. One thing that I do really think it's important is in this job in EMS, if you're going to teach skill-based, scenario-based training, you yourself as an instructor need to be clinically active. I think that's a really important concept. And it goes from that holds true for multiple reasons. Now, that being said, if you're teaching lecture and that's solely what you're doing, I think you can get by with not being clinically active and not treating patients. But if you're going to go to the skill-based, the scenario-based setting of teaching EMT and paramedic students, then you yourself need to be clinically active and seeing patients. And that may be a different venue for everyone, whether it's in hospital, in an ambulance, in a helicopter, you just need to be still doing active patient care. I think there's a couple reasons for that. There's the whole concept of, walk the walk, talk the talk. And, if you're working and you're teaching, you're still doing that. But I think also too, when you're clinically active, it adds another layer to what your students see and how your students see what you're doing. Perfect example of this is, paramedic students, they're doing rides on rescues. They're doing rides in hospitals. If you're clinically active, those students are going to see you bringing a patient in, and they're going to see you give report, and they're going to really have an honest look at, wow, is this person doing what they tell me, or are they just blowing smoke up my butt and they are a totally different person as a clinician? I think when you're clinically active, it adds a layer of vulnerability that your students can see. And you can go to those students that you've just dropped a patient off or just picked a patient up from and say, hey, what did you think of that patient? Is there anything that we missed? Is there anything that we could do better? Is there anything that you have questions on? Because a lot was probably going on with that patient. So, I think being clinically active while you're teaching is so important because, it adds another layer and your students kind of see you more as a clinician and less as an instructor. And it also kind of reminds the student is like, hey, we're all in this together. We're fighting the same fight, and I'm just as prone to the same mistakes as you are. And this is all a big learning moment. So I think being clinically active while instructing is really vital, especially if you're teaching that scenario-based, skill-based training.
I agree with you pretty much on everything you just said. I think that I don't like the mantra of those who can't do teach. You do hear that a lot. And that is true in some respects. Some people, that is certainly true. But I've always kind of, I've found it to be a dichotomy. Like, I want my instructors to be clinically active, but at the same time, I do see the need for full-time professional educators. And I think, how can you balance that? Because I don't expect some 55-year-old college professor to be out climbing in cars and starting lines in people's trailers and stuff. But I like that you brought up and you said that if you're doing lecture, you're probably fine to not be clinically active. I think if you're teaching the foundational, like EKG, here's a P wave, here's a QRS segment, here's how to tell a STEMI, here's pathophysiology, acid-base balance, you probably don't need to be clinically active anymore. I agree with you there.
That stuff's pretty static, right?
But it is painful to see some of these clinical instructors who are so out of the game and so out of touch that they're teaching students stuff that hasn't been done since like 2005, even before that. So it brings me to the question of, just because you're clinically active doesn't mean you're going to be a good instructor. So how do we vet people going into EMS education? Because there's no certification exam. And we all know that just because you were a good paramedic does not mean you're going to be a good educator.
Right. That's very true. There's no particular congruency between clinical competency and, education competency. So how do you vet those people? That's a great question. I think actually having a true solid interview and orientation process for these new instructors. I know, where I work, if we got a new instructor, we start them off in EMT lab. Can you explain the procedures? Can you do the foundational educational parts of this? Can you walk through a procedure? Can you adequately test? Can you mix it up with the students? And also we're trying to see, hey, can you act appropriately with the students? And then usually if the instructor is doing well in EMT, the other instructors feel comfortable with them and they're interested in moving over to medic, then we'll kind of slowly start to transition them over to the medic side. And, we, in the lab setting, we always use a 1:6 instructor to student ratio. So we'll always make sure we're putting them with more tenured instructor or tenured instructors, so they can kind of get a good idea of how that person is as an educator. That's kind of the best that we got. I think that we're really good at orienting the students. We're probably not so good at orienting the instructors. And I think we need to do more of that and I think in a better orientation, you help vet some of those folks that are kind of coming over to the education side. And a lot of education is kind of like a lot of clinical care. You got to know your stuff, obviously, and you got to be proficient. But at the end of the day, it's how do you connect with people? And can you explain something to different types of learners? Just like in the back of an ambulance, can you talk down different types of patients that are going through emotional distress? That's a skill within itself.
Oh, yeah. There is a well-known EMS educator who is brilliant. You listen to his material. It is good, and it is intricate. It is in depth. Very good material, but I have said you could play him for toddlers on methamphetamine to put them to sleep, because it's like listening to VCR instructions. You got to have an engaging instructor who can connect with. So what the hell does that mean? Connecting with the student.
Yeah.
I have always interpreted that to mean I can align with them and make them enthusiastic about learning. make them an engaged part of the learning process. It doesn't necessarily mean, oh, the student's going to like me and that they're going to think I'm a fun instructor, because I've had instructors who are incredibly personable and I like going to their class. I thought it was fun, but when it came to actually learning stuff, it was bullshit. I didn't learn anything. Like, we just kind of BS'd our way through class. So I think it's a balance of academic knowledge and being able to make people enthusiastic about the learning process. And that involves accountability. It involves the instructor holding people accountable to a degree.
You got to hold people accountable, and you got to also meet them where they're at a little bit too. You know, if a first semester student is having trouble with a certain concept, well, they're also a first semester student. And you have to kind of meet them, understand where they're at, and give them the tools to succeed. And also understand too, you got 2 more semesters to iron some of these issues out. You know, this is not the final product yet, so have a little patience. In regards to, engaging with students, so 2 things there. I think that, if we're looking at what's the definition of an expert, the broad definition, I think one of those things is going to be a person that can take the knowledge and discuss and explain it to all different levels of learners. They can explain and talk shop about a concept with your day 1 paramedic student and break it down in language that they're going to get and understand. But that same person can also have that same conversation with a peer or a physician or a higher up and change their language, change their delivery to appeal to that person. In my eyes, that ability to take the content, take the information and mold it to where that person is at, that really kind of is more of a game changer. And that, to me, kind of really strengthens what the definition of an expert is. Someone that can take the content, but then deliver it differently to different types of people with different expertise.
How do you deliver it differently?
So, you and I are probably going to talk about sedation and paralytics a lot different than a brand new paramedic student is going to. And I find what's super helpful, and this is going to sound a little corny, but I like to take a moment and ask the student, kind of usually day 1 when we're doing our introductions, what hobbies do you have? What do you do outside of class? And it can't be like working out because, that's something you should do. Tell me your hobbies. And, I find that if you find a good hobby and you kind of keep it in the back of your head, you can relate concepts. A perfect example would be if I got someone says, yeah, on my off time, I really like to cook. All right, cool. I'll remember that. I'll put that in my back pocket. And then once we get to intubation or once we get to RSI, we'll kind of talk about, setting all your stuff up and how you're going to set it up appropriately, how you're going to set it up where you like it. And then if they're having issues with that, I could be like, all right, take a step back. Let's say you're in the kitchen and you're making a stir fry. If you don't have all the ingredients out and ready to go, well, you're going to burn your shit and it's going to taste like crap. But if you have all your ingredients set up, ready to go, where you like them, where you're going to get them, it's going to calm you down and it's going to make the whole process a whole hell of a lot smoother. Another way you can go, if you got someone that is into music, let's say that plays guitar, or I play drums, you can kind of relate concepts of that. You're going to have to learn this bar or these bars a couple of times, and then we're going to add a couple more bars onto those and a couple more and a couple more. And by the time we're done, we're going to make a whole song. And you basically just layered on kind of in a rote way, describing how you evolve through a call. Well, we're going to get you knocked out on pre-arrival and primary assessment. And once you're good with that, then we're going to add a little bit more. We're going to add some treatment concepts. And once you're good with that, we're going to add on transport decision, transport mode, and transport care.
Cool. I like it.
Yeah. So yeah, let's get to the meat and potatoes. Let's talk some sims. Let's talk.
I think this is what's going to spice people up.
Yeah. Okay. Let's talk sims. So I'm really passionate about, we got to make the sim as realistic as possible. And first things first, let's get the airway mannequins off the tables. Let's get the babies off the tables. Let's get the mannequins off of the tables, because that is not where we treat patients. Agreed?
I agree.
Yeah. We can put them on the ground. That's totally, if we treat plenty of patients that are laying on the ground. Let's get chairs, let's get furniture. Let's kind of create a little bit more of a realistic scenario. We have, where I work, I'm lucky we have a indoor
So you
ambulance.
strap them upside down under a table and then you make the person hang by their feet and intubate them.
Yeah.
Right?
And what have you done? Just prepare them for this call that they're never going to see in their life?
That drives me nuts. We went and
it's performative.
It is. We went and we did this airway training day for a local paramedic program, and they had the whole intubation. I'm trying to be general here because people will know if I start to use terms.
Rodeo.
But thank you, rodeo. That is
Rodeo is what we would call
or
it.
goat
Yeah.
roping.
Yeah.
And the facilitators were pissed that we didn't use it. And we were like, no, this is not realistic. Like, you're not going to be crawling into a crawl space and intubating somebody who hung themselves in their crawl space while they are still hanging by a rope. Like, it's not realistic. So thank you for that.
Yeah, no problem. And it's like, what's the objective of that? You know, hey, listen, if you're looking to have fun and cut up and build some camaraderie, maybe that's what you should do, you know? Or if you got some extra time in lab and you're just looking to have fun, blow off some steam, by all means, go ahead. For learning, and like education, actually teaching, skill development, I don't really see that it serves much purpose. What serves a whole hell of a lot more purpose is putting that mannequin in the back of your mock ambulance, putting that mannequin in a home, or if, you know, all of our finances are a little different. You know, if you don't have a mock ambulance, you can put a stretcher in the lowest position with a mannequin on it, and you can make a little airway chair. You can make your mock ambulance. Because I think we need to kind of really learn these skills and run these scenarios in, you know, the settings that we're actually going to be doing it in.
100%.
Yeah. And then, you know, also too, it kind of comes down to, you know, just little things, little low cost things. How are we using moulage? You know, I'm not a moulage expert by any means, but I can take some Tegaderm, some red makeup, and I can make a through and through GSW. And I can put clothes on, and now I'm forcing you to cut clothes off and really do a good head to toe and really do a good physical assessment, not this like, oh, what do I see here? And then I'll give you feedback. I'll actually put it on there. You know, something I kind of do want to start to mess around with is getting some yellow makeup. You can make your mannequin look jaundiced when they walk in there. And all these little things, you know, add a little bit more realism to the scenario. And I understand it's silly, you know, I'm looking at myself, I'm putting makeup on a mannequin. Like what am I doing? But it adds layers to the scenario that really push on different stress responses that a student is
and it's going to generate memory
markers
markers in the brain. So if they see a yellow patient, they're going to hopefully automatically think there's some type of liver problem happening. You know what I think is stupid though? Are the mannequins whose nails light up neon blue and they're like cyanosis. It's like, no, that's ET.
Yeah. You need light up blue around the mouth. That's a little bit more realistic. But you know, and when you up the ante of these scenarios by using moulage, by using, you know, more normal environments, you know, you start to elicit stress responses in students, which I think is so important. I think a good scenario is obviously going to test, you know, assessment, clinical assessment, physical and history, and decision making and skill set. It's going to test all of those. But a really, really good scenario is also going to force some of those stress responses on the student. It's going to make maybe that heart rate get up to above 120, where those fine motor skills are going to be a little bit more difficult, and you're going to have to work through those. It's going to really cause, you know, that lack of perceived time versus actual time in high stress situations. And I think it can definitely cause, you know, you can elicit tunnel vision and issues with perspective on really good scenarios, especially when you put that patient in a mock living room. Now, you know, you can easily have a student that gets so tunnel visioned on, you know, that patient that they don't notice the pill bottle or the bottles that are sitting next to them. And then, you know, as far as the perceived time versus actual time thing that we like to do with our students, that I like to do with our students after a scenario, I'll say, hey, that was 15 minutes or that was 8 minutes. And they will always like look up at me and be like, oh my gosh, that felt like it was about 5 minutes, or that 15 minutes felt like 30 minutes. And it's really important that we kind of elicit those stress responses, because now we're a little bit more stress inoculated when we get out in the field.
I was just going to say, Mike Lauria has done a lot about stress inoculation and bringing it into medical training.
Okay. Yeah. And there's stuff there. And even if we're not fully stress inoculated by the time we get out into the field, at least we're aware. You know, we're aware that like, hey, I'm in this airway and I am extremely tunnel visioned right now. This is, you know, I need to be here, but I don't want to stay here for too long. And then perspective's one that I really love too. We get hit this a lot in cardiology when they're working codes, and they'll be all up on the patient, next to the monitor, doing the things, and then they'll get ROSC. And one of the first things we like to tell them when they get ROSC is, all right, I want you to stand up and take 2 steps back and now start to take the situation in. Because perspective is a lot different when you're sitting down next to the patient doing skills versus when you're kind of standing up, looking down, looking across everything a couple feet away. So yeah, good scenario training can really mimic life. Like I like to say, art imitates life in Sims sometimes, a lot of times.
One of the pitfalls I have seen with Sim is we used to have the ability on my first flight team to train at this multi-million-dollar sim lab, state-of-the-art everything. And I found that the quality of education sucked. Well, first off, because there were a lot of politics with you working with this sim lab, but that's an institutional problem that I'm sure have not been fixed since I left. But it would piss me off. Like, it was a pediatric hospitalist who ran the sim lab. That was her full-time job now. And we would do these like trauma scenarios. And she's like, I don't think that's a good use of training time because I don't think that's realistic. It's like, shut the fuck up. What do you know? Like,
yeah.
When have you criked somebody in a ditch? Like, just shut up. I digress. But the problem that I saw with the sim lab that I've heard with other simulation training is that the tech, as advanced as it is that the simulation would revolve around the tech rather than the tech serving as a facilitator for the simulation. Does that make sense? Did I word that correctly?
Yeah, that makes sense. Yeah, okay. I think we talked about this a little bit when we were at Recess X.
We did.
They want to use, you got new paramedic learners and we're putting A-lines on them and giving them all this stuff just because we want to show off our tech.
Oh, yeah, and you walk in and there's already an A-line up and it's like, oh, you're responding to grandma's house for chest pain. It's like, oh, she's got an A-line, and like, oh no, we have to keep that on because of the sim. So like, just don't forget about that.
Yeah, so I got, that's a bummer that's the experience and that's the stigma. We work with the paramedic program and the flight team I work with. We work very closely with a sim lab that is academic based, kind of very similar, high tech, high dollar accredited sim lab, and we do a lot of work with them, and I have got to say the experience is nothing like that. They have been excellent. They have been fantastic to our paramedic students. They have been fantastic to us on the flight side. They are really looking to mold the scenario to what we're working in and understanding where we're coming from. What I think is maybe, I don't know if it's unique about that sim center, but it definitely helps, is that in order to bring learners in there, you have to take their class. And it's an 8-hour class, and it has to do with sim development. This is how we're going to develop sims, and this is how we're going to debrief them. It's really the meat and potatoes of the class. Good class. But once you have that class, you can now bring learners into their sim lab, provided you have the time blocked off and have made the financial appropriations. But now you're the one that's debriefing your students. Which I think is so important. So now the learners are having, their true instructor debrief them, but that instructor also knows kind of the way to keep it organized, how these sims are written, and really how we want to debrief these successfully. So that's very important. And it's also really nice because me as the instructor, I can just put them in the sim and I leave. And that's mind blowing for them to be the only people in the room without an instructor running a sim. Just that alone just changes the dynamic significantly. I don't know if it makes them more nervous or less nervous, to be honest with you.
Yeah, but you're right. It does change up the dynamic. It's like, it's just us. Because, when you're a student and you're doing stuff in sim, you're always looking to the instructor, whether you realize it or not, like looking for those subtle cues of, do they agree with what I'm doing? Are they looking with this disapproving look?
Yeah, poker face.
Yeah.
Got a total poker face. Yeah. And, as far as the scenarios themselves, and, this is, outside of, high dollar sim lab, first things first, development of a sim is have objectives. What is the objective of this simulation? Because if I got an objective or objectives, I can really look for that. And if I've met all those objectives, I can cut the scenario short. I can make it go longer. So I think it's really important to have objectives. Like we were talking about hanging the mannequin upside down and this way and that way. Again, what's the objective of that? Are we really going to test airway proficiency on a once in a never in a lifetime setup,
Yeah.
is the objective to have fun? If the objective is to have fun, then hey, go at it. But what is, have objectives for these scenarios. And then also there's this concept, now you may have heard it, called lab magic out there, where we say, hey, I want an IV, and you just verbalize an IV and you get an IV.
Yeah.
Man, that
Yeah,
can
that's
really,
helpful.
yeah, that screws people up, man.
It does screw people up because when they get to the field and it's a 300-pound dialysis patient who needs that IV, now they get that tunnel vision, and 35 minutes has elapsed as they're trying on their 270th attempt to get a 24 gauge IV in that person. Because the sim has not served them, because it's like, all right, your partner started an IV for you.
Yeah, and listen, our mannequins don't give flashes. You can put IVs in them. There's fake veins, but it's not going to give you a flash. It is not like a realistic IV. I totally understand that. But when you make the student do the actual skill, let's continue with the example of an IV, it does a couple of things. Well, now the student's going to have to pull out all the stuff, make sure they have all the equipment ready, good to go, which is going to help in real life. Okay. Now they're going to put the tourniquet on, they're going to go through the IV, and now that's taking time. So they really get a true appreciation of how much time does it take to start an IV. And then it kind of helps or hinders with that tunnel vision concept, because paramedic students are notorious for treating the monitor and not the patient, especially in cardiology. They will sit there and look at that monitor the entire time. Read
the discussion on end-tidal CO2 on Instagram.
Yeah. Yep.
Anyway.
And paramedic students, no fault to them. They're trying to play the game. They are notoriously looking at that monitor. They will not stop looking at that monitor for an entire scenario, especially once we get to cardiology. And just the concept of making them do the IV, it pulls them away from that monitor, focuses them on something else for a little bit, and gives them appreciation of, hey, getting an IV takes time. Making the decision to do it, it takes a little bit of time, but actually doing it is going to take some time. And how does that fit into your scenario? Because if we're just saying, oh yeah, there's your IV, we build this mindset of instant gratification on that. Oh yeah, whenever you get an IV, you're gonna have it. It's gonna happen. But the inverse to like less lab magic or no lab magic is how do you make sure you're allotting your time so that each one of your students gets adequate reps? I get that. I understand that. But we really need to avoid lab magic. We need to do the skills to the fullest of our ability. If you're going to give a med, I want to see you pull it out. I want to see you pull the appropriate syringe out. I don't need you to necessarily be messing with needles or sharps, but I want to see you pull up how many mLs in air you're going to give. And then I want you to, push it slowly and effectively.
Yes, that is one of actually, I experienced this too, looking back 20 plus years ago now. I found that to be one of the biggest stumbling blocks when I was on my field internship, because we didn't do a lot of med administration practice. We drilled skills. Mm-hmm. I knew what all the meds did, but when it came to picking a syringe size, picking which needle to use, and actually drawing up the med, I hadn't done a lot of that. Mm-hmm. Because in the hospital, the nurse would draw up the med and be like, here, go give this to them. Or in class, you would drill the meds, but we wouldn't do a lot of medication administration. And I found myself being in the back of this Philly Fire ambulance with Mark, my preceptor, being like, what the hell are you doing? As I'm using like a 24 gauge needle and a 20 cc syringe to draw up adenosine.
Yeah. And now you're seeing them do a little bit more math. So now you know that they do understand concentration, or they don't understand concentration.
Yes.
Little things like that will up the ante of your scenario significantly.
Yes.
And so yeah, no lab magic. Let's do the skills to the fullest of our ability. I tell the students, hey, listen, if you want to do a skill, I want you to do it up until I say you can't do that to this mannequin. I'll stop you. Keep doing the skill, rock out. And if hey, let's say you can't needle decompress this particular mannequin, I'll say, all right, you're good. Stop right there. And then we're good. But if you can at all costs, the goal is to not use lab magic.
Yeah. That's a good point. I had an aha moment while we're talking about lessons learned with sim. As people listening to the podcast may have heard, I corrected someone this summer. I joked during Haney had me come present that class at his resus conference, which is for residents, ER residents in the Philadelphia area. And I joked when I started, I was like, I'm offended that balloons have not fallen from the ceiling, because this is the 100,000th time I've talked about this case. Anyway, so during everybody that listens to the podcast has heard that I criked the patient. It was a successful crike, but he actually got worse. And I felt very defeated. He didn't die and he did fine. So the crike was obviously ultimately successful. But there in the moment, like, we were ventilating him successfully, but his vital signs got worse. And he massive blood aspiration from the wound that he had, not from the crike, from the wound that he inflicted on himself. But I felt very, very defeated. And I had this aha moment that in the 200 million times I have done a surgical airway simulation, or any simulation for that matter, the patient always ends up getting better. They're always like, all right, sats are climbing. And then when you're in that moment of stress and you do that skill, even if it's successful and the patient doesn't get better, you start to really beat yourself up and you think you did something wrong. And I think we need to include in simulation that sometimes your interventions don't work, because that is real world. Like, I did a simulation once. It was a pregnant patient, critical care transport, high risk OB. She had an eclamptic seizure. So what do? You give the magnesium. They're like, okay, seizure is stopping. Like, no, maybe we need to do a simulation and have that patient continue to seize and not get better, and then aspirate and need airway management, and tell the student that, like, hey, you did everything right. It's okay. It's not okay that the patient got worse, but you did everything right. And it's okay to realize that sometimes, despite your best efforts, like, Mother Nature is just going to make that patient worse.
Yeah.
Because I think
it kind of goes.
Go ahead, please.
Yeah. It touches on lab magic, like, oh, I do skill, patient gets better. That's kind of lab magic. That's not really how the real world works.
Yeah. Yeah, for sure.
Yeah. And also too, it's, hey, let's say you just crike someone that's severely aspirated and has a lot of blood secretion, whatever, in their lungs. That SAT might come up eventually, but it might take a while to recruit lung and for that SAT to come up. So little things like, we utilize an iSimulate a lot, and I can put a timer on there, and I can start a 5-minute timer, and that SAT will slowly creep up over 5 minutes.
Yes,
or
thank
10
you.
minutes,
Because people think, all right, I applied 5 of PEEP. All right, they're not better. Like, let me crank it up even more. And like, within 2 minutes, there are 20 of PEEP. And it's like, hey, if you gave them 2 minutes to let that PEEP change sink in.
Yeah, what we forget is so much of what we, not everything that we do, but so much of what we do takes time to work. It just takes time to work. And then, another place where we like to use that feature of, the SAT dropping or changing over time is when we teach RSI. All right, you give your paralytic, as soon as you stop ventilating, I'm setting if you've used your apneic oxygenation, proper positioning, all that stuff, I'm going to let that SAT hold for 90 seconds. I'm going to put a 90-second timer on it. And at 90 seconds, that's when it's going to start to dip below 93, 92, 91. So it's I'm not here to rep iSimulate by any means, but it's a really cool feature that helps the student really appreciate time. And then it kind of links back into perceived time versus actual time, like we talked about earlier.
Okay.
Yeah. So let's talk about, we talked about the scenario development. We talked about, kind of in scenario, that lab magic, and how we really want to do our skills to the fullest extent. Let's talk about, where the gold is. And the gold is in the debrief. That's where kind of you have those aha moments with students, and you really kind of can that's where the true learning starts, right? Is in the debrief. So a couple things about debriefing. It's really easy, especially as paramedic EMT instructors, to sit there and take notes during a scenario and say, all right, scenario over. Here's what you did great. Here's what you kind of stunk at. And here's what you got to get better at. It's very easy to just come off with a list. But what if we flip the tables, and when the scenario ends, I like to have every student put down what you're holding. Don't start packing up. We'll do that, and take a deep breath and stuff like that. All right. Now I want you to tell me, how'd you feel about that? Okay. And what do you think you did well? And what do you think you could improve on? Because what you'll notice is that really kind of that sort of debrief style, it causes, those intrinsic aha moments. And now the student is finding those things that you had on your list of things to improve on themselves, as opposed to you just calling them out. And if they can find, at least they're not going to find all of the issues that they did good and bad with, but if they can find some of those issues themselves, they're going to be their own worst critic. So I think that kind of introspective approach to debriefing is Very helpful. And now, once we do that introspective approach, and if there's anything missed, we can say, hey, yeah, you did really well on this, this, and this. Here's some stuff that you didn't bring up that you need to work on. And then also, when you ask a student right after the scenario, hey, how did you feel about that? If they rocked the scenario and they don't feel like they did that well, that's a confidence issue. We need to work on confidence. The skills, what you're doing, trust yourself, versus the other alternative is you have a student that does very poorly on the scenario, or pretty poorly on the scenario, and they think they rocked it. Okay, that's an overconfidence issue, and we definitely need to work on that.
Yeah. Again, I completely agree. How do you work on an overconfident student? That's the age-old question.
Yeah, that's really hard.
That is tough.
Yeah, I think this job has ways of humbling you, and that learner is going to come across a humbling moment at some point or another. And I think as the instructor, the best thing you can do is make them very aware of that in this job, we need to ride a fine line of confidence and cockiness, and we need to stay on the confidence side of that. And that is a challenging learner. I will say though, and this is just my personal experience, you see that learner a little bit less than you do the student that has the knowledge and the ability that's just a little not confident in themselves. You tend to see that, at least I tend to see that a little bit more.
Mm-hmm. Yeah, for sure.
And that might be different in the student realm versus the employee education realm.
Yeah. You also have to be, one of the worst things that I see is that, because there is a little bit of conflict involved when you're debriefing people. It's just natural. I don't mean like you have to be a dick, but one of the worst things that I think that you can do while debriefing is give criticism and tell people, but it's okay when it's not. Like, you missed a STEMI, but it's all right because, you got him to the hospital and you did everything else well. Like, no, that's not okay. No. I think you need to, you don't want to break them down and be nasty, but you need to make it known in no uncertain terms that what you screwed up was a screw up, and that will have real world consequences.
Sure. And just like any other, if you're gonna bring up a problem, bring up a solution also. Hey, you missed that STEMI. Your 12 lead recognition needs some work. True. Here's where you should go. Here's where you should go to find that. And we have resources for you if you want to take some extra time, one-on-one time with an instructor to review 12 leads, and whatever you're having trouble.
If you're in a group, have another student explain the STEMI. Just be like, who here identified the STEMI? Can you explain this to the group?
Right. And now I'm testing their knowledge, which is great too.
Yeah.
Yeah. So the debrief is all where it's at. And if you can push the student to find their mistakes, it's going to be that much more fruitful for them, because most students are going to beat themselves up probably worse than you're going to beat them up, to be honest with you, a lot of the times, because we are our own worst critic. At least the ones that want to be there, we can be our own worst critic.
Yeah.
And then, in debriefing, there's the whole concept of, we want to make it a safe learning environment. That is a common phrase. We want a safe learning environment. What is a safe learning? What does that mean? And I think that means something different to everyone else. What a safe learning environment means to me personally is set up an area where the student can make full speed mistakes. We encourage full speed mistakes. And what do I mean when I say a full speed mistake? Well, I want to see the mistake of, I gave you bronchoconstriction. You thought it was pulmonary edema. You treated pulmonary edema to a T, rocked and rolled, but you didn't stop, and you stuck to your guns and you did it. Okay. We got to go back and we got to talk about the nuances and the difference of type 1, type 2 respiratory stress. We can do that. Not a problem. The mistake that we don't want to see, or that we don't encourage, is giving up on the scenario. Well, I'm frazzled. I don't know what's going on. I'm not, I'm just going to sit here on the bench seat and kind of ride it out to the hospital. That's the mistake we don't want to see. That's the low speed mistake, and that usually stems from confidence issues more often than not. But again, that's not how the real world works. If you get stumped on a patient, you got to keep on trucking, and you got to keep on doing the thing, and keep on digging and digging and digging. So those are the mistakes that we don't want to see. But if you make the full speed mistake, you think one A and it was B the entire time, that's a teachable moment. We can work through that. And we would much rather you kill the plastic, kill the rubber, maim it, do what you want to, because it's worth that learning experience. And so you don't take that knowledge or those bad habits out to the streets.
I encourage bad decisions. I've taken this through my whole life, but what do I mean by that is I would much rather have a student make a poor decision or a wrong decision than not make a decision, because I can very easily, like you said, correct that difference between type 1, type 2 respiratory distress. That is an easy bread and butter fix for an educator. And those are often formative moments for the student that we all have had. It's a natural part of the learning process. I would rather have them do that because it is I would say almost impossible to train somebody to be able to make a decision. Like, that is going deep into psychology that I personally don't feel that I'm qualified to do. I've tried, but those people who can't make a decision are very difficult to deal with. And I found that if they're like that in paramedic school, they tend to be like that 20 years into their career.
Yeah.
Like, how do you
That's
intervene?
that's a challenging one to overcome. I also find what's really challenging is, in second semester, we do cardiology. So a lot of, for lack of a better term, algorithmic thinking. Okay. All my causes of AFib, RVR are going to be cardiac related when we're doing cardiology. And how do you, what's really hard is taking that student out of cardiology and then flipping them over to third semester where, okay, now we're going to teach you that the patient doesn't read the protocols and that two things, more than one thing can be true. And hey, not all AFib RVR is caused by cardiac issue. It could
do
be
not
caused
give
by
cortisem to that GI bleed.
Right. Yes. And that's kind of the goal where we're looking for by the end of paramedic school. Yeah, they know the protocols, they know the knowledge, they have all that, but can they do the critical thinking? And that's where I've changed a lot as an instructor. I feel like our scenarios that I wrote for test out for our paramedic students used to be this medical trauma. We're going to see them do this skill and that skill and this skill. And it's kind of, again, we're kind of going back to the, okay, I'm seeing that you can handle a patient that you might get once in your career. And I kind of adopted a little bit of a less is more approach. Now, let's give you that gentleman in AFib RVR that also has had nausea, vomiting, and diarrhea for 7 days, is an alcoholic, and is also a little bit hot to the touch. That's where the critical thinking comes in. Can you recognize your different types of shock and treat those shocks appropriately? Now we're seeing a lot more critical thinking with our paramedic students on calls that you literally could get your first day as a cleared paramedic.
Yeah, for sure.
Yeah.
So what else do you have?
Let's see. I think really kind of the big trend is, or the big thing that we're hitting at is, let's stop it with the scenarios that, you're never going to see in your lifetime, or you may see once. The person hanging upside down, the medical trauma thing, this and that. Yeah, they're nice, but really what's the objective? What's it proven? Let's show that these students have a really good grasp of critical thinking by the time we get them out of paramedic school. Let's make sure they know there are different types of shock. Let's make sure that they know that, hey, you can't give fluids to every type of shock. As a matter of fact, there's certain types of shock that you'll kill if you give fluid. There's certain types of shock that you might help if you give fluid. So just getting that critical thinking down is so valuable. Yeah, I think it really is a game changer as far as the product of student that you put out into the real world. I always love the phone call or the text from students past that says, hey, remember that scenario you gave me? Yeah, I got that like my first day as a cleared medic. And it was hard, but I got through it because of you. Or, I ran on that, college age female, came in as an anxiety attack, turned out to be a PE. Well, I got that from a scenario you gave me. That's where the gold's at right there when you get
Thank
that.
God I saw her end title was 22.
Did you give her high dose nitro also?
Yeah.
Just stir that pot, man. Just stir that pot. Oh, and also too, we're going back to scenario development is, I was talking to Steve Haywood at Recess X. I got in a really good conversation with Steve and with Melody Bishop about Sims. And, Steve's input is, every scenario that you give has signal versus noise. And that really stuck with me.
That's profound shit right there.
It is some profound shit, man. So the noise is okay. We'll continue on the pulmonary edema stuff because this is really good. The noise for a scenario would be, I got this gentleman in respiratory distress. He's got an inhaler sitting next to him. He's got 80 different meds. He's got a wife that's screaming. That's all noise. What's the signal? Well, the signal is he missed dialysis. And, maybe there's a boiling pot of hot dogs, so he's got a high salt diet. So it's really kind of tapering in signal versus noise in all your scenarios. And I think, you get that newer paramedic student first semester, and you're probably putting more signal than you are noise, right? 'Cause you want to build some confidence. But then as you progress in the second and third semester, it kind of should be an equal amount of signal with noise. And maybe the signal is starting to or maybe the noise is starting to outweigh the signal a little bit to make it a little bit more difficult to find out what's going on.
Yeah.
Yeah. And then, if we're going on profound things, one thing that Melody said to me, and I actually wrote this down, so I hope I'm not paraphrasing her too much. She said, what if this scenario is just as much what if this scenario is just as much of a reflection of you as it is the students?
Yeah.
And that got me a little bit, is it a reflection of how you're teaching, how you're debriefing, how you're setting up the scenario? And it is.
Yeah. No, that's deep. Do you have an example of what that would be?
Well, I think we can go back to the scenario development. Again, if you hang the mannequin upside down and have them intubate it, or put the mannequin on a table and they're constantly intubating on a table, then when they go to intubate in real life, they're not going to be like, hey, I can put this bed up 30 degrees. Or, I'm really good at intubation when the patient's hanging upside down.
Yes.
And that's kind of a reflection of you. And I hate to be on a soapbox, but the mannequin on the table thing, the mannequin on the table. Okay, listen, if you got something that's like a vomiting airway mannequin, or like you're using pig trachs, or, any sort of raw food, listen, yeah, put that on a table with a tarp. I get it. But if you're teaching intubation on a mannequin, or anything, again, put that mannequin where it's supposed to be, because we get a lot of students, they're like, oh, I talked about raising the head of the bed 30 degrees to intubate, but every time I intubated, the mannequin was, on the table. So I didn't actually do it. And I didn't have that memory
all the
to
time.
Do it. Yeah. Pediatrics on tables. I see a lot of pediatric scenarios run on tables. And mannequins on tables, it's great if you got dirty stuff or stuff that's going to get dirty. But beyond that, it's for people that are selling medical devices.
Yeah. Well, good shit. You got anything you want to?
That's it, man. This has been a really good
great review. You're very eloquent on this stuff.
Thanks, man. Thanks. I try.
Yeah, no
This has all been a surreal and enjoyable moment to be on a podcast that I actively listen to. So, very cool.
Anytime,
thank you for the
man.
opportunity.
Yeah. All right. Well, Paul, thank you. I'm going to hit stop.
All right, Mike.